Good afternoon to everybody. Marián Švajdler speaking. Welcome back to our multi-head Tuesday seminar at Bioptická. My first case is a brain tumor case. This is a young adult female patient. And this is already recurrent brain tumor, which was resected probably 1 year ago, and the patient is still alive. And the first diagnosis made at the referring laboratory was, I don't know what it is, probably it's a metastatic small cell carcinoma of neuroendocrine type. There is one problem. The patient is still alive 1 year after the diagnosis, the first point. And the second point is it's young female patient with no smoking history or whatever, or history of any other tumor. So she was investigated completely and there is no other lesion in the body, only in the brain. And it's the tumor is involving temporal and occipital lobe, so it's supratentorial tumor. And as you can see, the morphology is essentially small cell carcinoma-like, so embryonal morphology when speaking about brain tumors. And there is quite a lot of mitotic figures. There was small spot of necrosis in this biopsy. Maybe you can call this microvascular proliferation, I don't know, maybe yes, probably yes. So the morphology is high-grade tumor. In addition to having the small cell component, the tumor is sprinkled with these, maybe I cannot focus, yeah. There are some big, bizarre-looking cells in addition to the small cell component. Immunohistochemically, the lesion is negative for all cytokeratins used, cytokeratin cocktail, EMA. It's negative for MOC31, negative for Claudin-4, negative for NSM1, neuroendocrine marker, negative for chromogranin, very focally positive for synaptophysin. I will show you. So maybe there is some patchy, weak positivity for synaptophysin. Not really something great, yeah. The tumor is positive for P53, so it's clearly overexpressed. It's positive for P16, diffusely. And retinoblastoma protein staining is lost in the tumor. And surprisingly, there is very weak and focal TTF1 positivity. So still, we have tumor negative for cytokeratins, but P53 positive, TTF1 focally positive, a little bit synaptophysin positive, loss of retinoblastoma protein staining. It's quite suggestive of metastatic small cell carcinoma, but it's not, okay? GFAP, glial fibrillary acidic protein, was negative. OLIC2 was negative, so we have performed, this is OLIC2 staining, it's negative. We have performed NGS and methylation profiling. And it came back with mutation in histone H3, with mutation with G34 mutation. So it's not that midline glioma mutation H3 K27 27 or 28 mutation, but instead it's G34 mutation. So the diagnosis is hemispheric H3 G34 mutated glioma. This is a new entity in the most recent WHO classification. It's grouped with other pediatric type of high-grade gliomas. And the morphology typically is of glioblastoma, or just like in our case, embryonal undifferentiated tumor. I would call it small cell carcinoma-like or embryonal tumor-like lesion. This entity affects mostly children and very young adult patients. So this is probably a little bit older, but still I would call it young adult patient.
The methylation profiling clustered with gliomas or clustered with different carcinomas?
No. It's a very strict and well-defined category of H3-G34 mutated glioma. So it's hemispheric supratentorial diffuse high-grade glioma. Its entity. Yeah.
Was it known before methylation, or methylation discovered this?
Yeah, it was known before methylation, the tumor was identified by NGS sequencing, finding this histone H3 mutation, but not that particular type of mutation which is typical for diffuse midline glioma.
Without molecular or methylation, you cannot diagnose this?
You cannot, essentially, yeah. It's high-grade lesion, high-grade glioma, and in most cases, OLIC2 is negative, GFAP is only focally weakly positive or completely negative, so it does not show glial immunophenotype. And with that morphology, I would guess that in the past, probably many of these tumors were diagnosed as metastatic small cell carcinoma or whatever, or embryonal NOS tumors.
In young patients.
In young patients, yeah. So this is probably second or third example of that tumor in our registry.
What was the mutation again?
It's H3G34. Okay, I've got another case. This is a cytology. This should be easy one, but it's old patient with pleural effusion, and there is he's got a history of urothelial carcinoma, and he's got pleural effusion, which looks like this. This is, let's say, easy case, but I would like to demonstrate my approach to effusions. So this is really very cellular effusion, and we see these epithelioid-looking cells. These are not really bad looking because, in fact, reactive mesothelial cells may look much worse than these cells. But it's still quite monotonous, which is quite suspicious. So could it be metastatic urothelial carcinoma? I would say it could, but it looks low grade and not that very much high grade as you would expect for metastatic urothelial carcinoma. So my first step in every case like this is to confirm the presence of epithelial cells. So it's not mesothelial cells or macrophages, and I would stain for Claudin 4 together with MOC31 or BREP4 antibody, and it's positive. Okay, so this is a confirmation we've got epithelial cells there, and it's not mesothelial cells. Yeah. So mesothelial cells may stain with these markers as well, but not as strong as these, and not as diffuse as this. So these are. So cells were negative for P, for T, for GATA3, for uroplakin 2, CK5-6. Everything was negative. We are having older patient, former maybe smoker, So I have added napsin A staining, which is nicely positive, and TTF1 staining, nicely positive. So it's adenocarcinoma of lung origin. Yeah. So this is my approach. I first do MOC 31 together with Claudin 4, together with some macrophages markers. I prefer CD 163 and calretinin staining for mesothelial cells. And in the second step, when epithelial origin of these cells is confirmed, I would go for second round of antibodies, and it depends on the clinical scenario. In this case, I have applied TTF1 and napsin A and urothelial markers together, okay, because I was suspicious it would not be urothelial carcinoma, but lung carcinoma instead. Okay. So easy. This is very nice example. This is nice case. This is a lymph node from the axilla from the neck. I'm sorry, from the neck, and it's older female patient. And you can see that the architecture of the lymph node is not very well preserved, so something is going on there. And in high magnification, there were these necrotic foci. So at first I was like, it's some kind of necrotizing lymph adenitis with several differential diagnostic options. But if you look around, you start seeing there are some suspicious cells there. And in fact, there are many of these cells there, okay? All right. So there are several differential diagnostic options, and you have to perform immunohistochemical staining. I will show many more of these cells. Some of these quite ugly looking, and some cells were multinucleated, but still there were multiple foci of necrosis there. And another helpful clue are these fibrous septa. It's not very prominent here, but if you look at the capsule of the node, it's already a little bit fibrotic, and there are some fibrous, not very prominent, but there are fibrous septa.
Where is it again? On the neck?
Sorry?
On the neck, you said?
On the neck, on the neck. Yeah, so this is CD30 staining, which nicely highlights many almost confluent sheets of these big cells. And if you look closely, big cells, and some cells show this very typical dot-like expression of CD30. So these clearly are not non-neoplastic immunoblasts, but neoplastic cells. CD15 staining, again nicely showing positivity in big cells. In addition, MOON1 was positive. What I want to see in this kind of lymphoma, because it's lymphoma, we already know it, it's PAX5 staining, which in these big cells shows these very weak dim positivities. typically it's a little bit stronger, but it wants to be positive, but it's very, very weak, okay? And this is very typical, this very weak positivity for PAX5. And other markers like CD35, CD5, CD3 were negative. EBV LMP1 was negative in this case, but it could be positive. The diagnosis is classical Hodgkin lymphoma, nodular sclerosis type, and syncycial variant. So we've got this huge amount of almost diffusely growing syncycia of tumoral cells with central necrosis. So it's a mimic of necrotizing lymphadenitis, and you should pay attention to atypical Hodgkin and RS cells. Okay, this is a consult case. It's a metastatic lesion from the liver. And the only information is that there is something around duodenum in the patient, but it was not biopsied. They biopsied only liver met. And it's young adult patient. So what we see is, I would call it epithelioid cell tumor, solid growing with a little bit edema. It's very monotonous and negative for cytokeratin stains, so it's not epithelial. There were quite prominent mitotic figures there.
The dog1 stain.
Yeah, okay. So dog1 and CD117 are diffusely positive.
SDHB.
And SDHB showed loss of expression. So it's SDH-deficient GIST. This is SDH. You have to pay attention to positivity in your internal control. The endothelial cells, stromal cells are positive and tumoral cells are negative. So it's metastatic SDH deficient GIST, and probably not of duodenal but gastric origin, because almost all SDH deficient GISTs are coming from the stomach, not from other parts of GIT. Okay, so these tumors typically behave like less aggressive compared to SDH proficient GISTs. Frequently occur in children and young adults and are frequently syndrome associated, Carney complex or Carney-Stratakis syndrome. Yeah. Carney-Stratakis syndrome. Yeah.
Not Carney complex.
So yeah, but you have also you may have SDH deficient GIST in Carney complex. Carney complex, and there is methylation of the promoter of the SDH genes. So it's not inherited. It's most frequently sporadic and somatic. So,
in contrast to most mesenchymal tumors, they metastasize to lymph nodes. Mesenchymal tumors, sarcomas usually don't metastasize to lymph nodes, not typically. But this one metastasizes to lymph nodes, and even the cases with metastatic disease in lymph nodes have good prognosis.
Yeah.
I don't know how about with metastasis in liver.
It's different methylation clustering than the rest of
It's a different tumor.
Still in metastatic setting, these are mostly non-progressive diseases and patients survive for many years without treatment. Importantly, biological treatment is not working for these SDH-deficient GIST, so you cannot give them imatinib. And yeah, also risk stratification based on the size and number of mitotic figures is not working for these subtypes of GIST. So it's essentially separate entity. Yeah. Okay, this is quite a young female patient with brain tumor again. Which looks very high grade. Okay, so it's cellular atypical cells, microvascular proliferation, some necrosis was present. Yeah, it's here. So it's typical morphology of glioblastoma, right? And the tumor was IDH1 negative by immunohistochemistry as well as by molecular genetics. And in addition, did not show typical changes for IDH-wildtype glioblastoma. So this is what we usually do. We have a young patient with morphology of glioblastoma and not showing typical immunoprofile of glioblastoma IDH-wildtype, which is typical for older adult population. We do additional testing because it could be something else. It could be glioma of pediatric type, and sometimes these tumors show rearrangements of receptor tyrosine kinases and have like good therapeutic targets. So we have performed some testing. We didn't find anything targetable, I believe. But the tumor was clustered by methylation profiling as pediatric type diffuse high-grade glioma, RTK1 subtype, subclass A. So it's something new, novel, and we don't know what does that mean. But it's still high-grade tumor. It's not adult type glioblastoma. It's pediatric high-grade glioma, H3 and IDH wildtype, essentially. So without methylation profiling, you won't be able to classify the tumor correctly. Another causal case, another brain tumor. In this case, it's older adult patient, and it was sent with the diagnosis, I don't know what it is, because it looked like this, showed completely sarcoma-like morphology. With some necrosis. Maybe here. So some atypical looking sarcoma-like cells and nothing else to show. So when the question was, is this a glioma, glioblastoma, gliosarcoma, or some kind of sarcoma, or metastatic melanoma, or whatever. Okay, so the lesion fortunately it showed focal positivity for GFAP and S100 protein and very occasional OLIC2 positivity, so some glial markers were positive, and in addition Peter gene mutation was confirmed, which when differentiating from melanoma is not sufficient because the promoter of third gene is frequently mutated in melanoma as well. So we had to do more, and we performed methylation profiling, and the tumor was clustered with 99% with glioblastoma IDH-wildtype. So I would call this Gliosarcoma IDH-wildtype. Okay. Another very nice consult case. This is an adult patient, very young, 24-year-old male. And this was a tumor extra-axial in the region of C3, so cervical spine extra-axial lesion. And it was sent with the diagnosis of maybe malignant meningioma or metastatic epithelial tumor or melanoma, something malignant, yeah, but no correct diagnosis. And we see this solid looking, almost sarcoma-like, little bit epithelioid looking tumor, atypical cells with vesicular nuclei, quite prominent nucleoli, quite a number of mitotic figures in the middle, yeah, atypical. And yeah, by immunohistochemistry, we have this diffuse cytokeratins positivity. So could it be some kind of undifferentiated carcinoma? Yeah, maybe yes, but EMA staining was positive and some other. And
How old was the patient again?
24. Yeah, but I will show you one more antibody, and this is very nice nuclear positivity for brachyury.
SMART-B1?
Brachyury.
SMART-B1?
SMART-B1 is lost in the tumor. So the diagnosis is poorly differentiated chordoma. Okay, we don't have this well-differentiated component to call it undifferentiated, and in addition, loss of SMART-B1 staining is typical for poorly differentiated chordoma, and the tumor was clustered by methylation profiling.
Brachyury was positive?
Positive, yeah.
Yeah, nice, yeah.
So chordomas typically arise along the spine, and this is a special variant, much more aggressive, typically for younger patients, more common in the skull base, but it can be anywhere along the spine axis. So very bad for the patient.
Okay, this is the lung biopsy, again consult case. See normal lungs here and something wrong here. So this solid looking, solid growing tumorous lesion composed of these quite monotonous looking oval roundish cells. There was some mitotic activity, but we have to search for mitosis. And yeah, essentially all antibodies they used were negative. And I have applied this particular antibody. It's almost negative in the middle, but it's fixation artifact and it's positive at the periphery. And this is STAT6 staining. So this is a metastatic solitary fibrous tumor, and the primary origin in this case were meninges. So this is proof of concept that it's a malignant kind of lesion in some situations. So originally this tumor was described in the thoracic cavity at the pleural surface. And after that, it was realized that it's some kind of ubiquitous fibroblastic kind of tumor and may occur at meningeal sites, where it was until recently called still hemangiopericytoma dash solitary fibrous tumor, but nowadays it's called only solitary fibrous tumor in the CNS locations. Okay, my next case is older male, and this is a soft tissue excision from, I believe, from lumbar region. So some skeletal muscle and fatty tissue, and this lesion. So very ugly looking pleomorphic atypical cells in fibroblastic and some eosinophilic, I would call it osteoid matrix. So by radiology, there was no connection to any bone structure. And the lesion was immunohistochemically positive for SADB2 and negative for MDM2. These were only two antibodies I have used. And PRAME was negative. I used PRAME. Okay, so this is example of extraskeletal high-grade osteosarcoma. You should always rule out metastasis from another location, and you should rule out connection to an underlying bone, and then you can call it extraskeletal osteosarcoma. In addition, you have to think about some other possibilities like heterologous differentiation in other tumor types. This is why I perform PRAME, because sometimes melanoma may the differentiated may show osteosarcoma-like morphology, and additionally, the differentiated liposarcoma may have quite rarely osteosarcoma morphology, but MDM2 was negative. Okay, so very rare example of extraskeletal osteosarcoma of soft tissue. And yeah, maybe I will. Okay, so the last case, yeah, from my side. This is another consult case. This is core needle biopsy from the breast. It's middle or older lady. And it's a lesion composed of this quite monotonous population of innocuous looking cells, nothing worrisome, no mitotic figures, no big atypia. a little bit maybe clear cell change. No metatic figures, no necrosis, nothing. Okay, the lesion, if you stain for that, and it was probably stained, will be positive for hormone receptors. It's very typical, and you can easily mistake this for carcinoma, but it's not, because epithelial markers will be negative, and there is typical, yeah, maybe. I will show you first. Androgen receptors are positive. Retinoblastoma protein is lost with internal positivity in residual stromal cells. And there is variable desmin positivity. I'm not sure whether we have desmin here. I've lost my desmin staining, but it typically shows desmin positivity. So the diagnosis of is Mammary type myofibroblastoma. Okay, be careful not to confuse the lesion, not to confuse the lesion with carcinoma because of estrogenic and progesterone receptor positivity. Maybe I will show you that. Oh, this is 17-year-old female, so teenager girl with the tumor of the lungs. Lungs or mediastinum? Yeah, the lungs. Lungs were involved. This is original IgE, it's not ours, but still it's quite nice. So we see highly malignant, solid, basaloid looking something, but there are some foci of
Not carcinoma.
yeah. I'm not sure whether there's some obvious squamous cell differentiation. I believe there was something. I could not find this. So it's undifferentiated basaloid-looking tumor in the midline, most frequently in the mediastinum, but sometimes it involves lungs, and you should think about several entities, and we fortunately have working NUT antibody, and this is nicely nuclear NUT protein positivity, so this is a NUT carcinoma. And by molecular genetics we have confirmed very typical rearrangement NOT and BRT, I don't know what rearrangement. Okay, that very common. And it's quite important because there are some inhibitors used in clinical trials, but I believe it's
BRD4, I think. BRD4,
yeah. But I'm not sure whether this biologic treatment is working. And maybe in some patients, yes, but it's not very successful in long term for the survival of the patients. Yeah. The next tumors is L3 extraaxial tumor, so in the spine. This is very typical example of that entity. What is very typical for this kind of tumor are these collagen fibers, almost amiantoid-like fibers. And it looks a little bit meningothelial. The cells are maybe here. But in addition, the tumor shows this clear cell morphology. together with these collagen fibers, this is quite suggestive of clear cell meningioma. These tumors typically have SMARCA E1 alterations, and we have confirmed the mutations in SMARC E1 genes. This is quite important because in many cases this is germline, so it may be part of syndrome, and it's recommended to test all patients with clear cell meningioma for that SMARC E1 gene mutations.
What other tumors do they have, or what others?
I'm not sure. These tumors are graded as WHO grade 2 by definition, so they behave more aggressively and may be inherited in a syndromatic way. And this was my last case.
Good afternoon, it's Michael Jr. here. Just a few cases. The first one was a male patient, 60-year-old, with a prominence in his stomach body. We got just this single slide with these few small fragments. So not very abundant material. So you can see corporal mucosa with some chronic inflammation, but nothing really striking. But here, in between the glands, there is something happening. Intestinal metaplasia as well, and this fragment is probably the best. You can still see some corporal glands, and then this proliferation of relatively blunt-looking cells, somewhat spindled, round or spindled. And it seems that they are kind of similar to the cells which are here. So probably this is just one type of cells. The tumor is growing infiltratively into the mucosa. So right now you should prepare some differential diagnosis. Could it be carcinoma? It probably could, but it's not very typical. It's not. It's not. It wouldn't be typical morphology because it's not atypical. They are not ugly-looking cells. No significant mitotic activity. You have here intestinal metaplasia, but I don't see any dysplasia in the epithelium here. So unlikely carcinoma. You can think of some mesenchymal tumors. Could it be GIST? Definitely, it could be GIST. So that's surely number one differential. Could it be melanoma? Yes, possible, but still unlikely because again, you don't see any mitotic activity. Melanomas, especially metastatic melanomas, they would have plenty of mitotic figures. Maybe if we try hard, we can find one mitosis here, but not more than that. Could it be some neuroendocrine tumor? Yes, this probably would be like number two differential. But GIST is definitely number one. So we have two very good GIST markers. One is DOG1, obviously. This is the most sensitive and very specific. And the second one is CD117, which is still very sensitive, but less than DOG1 and less specific. I hope I didn't mismatch those two terms. So this is, I'm showing DOG1. I'll try to find the tissue as well. So the mucosa, normal. And here we have the fragment with the tumor. So here's something is staining here. Is it the tumor? Probably. Yes, these are the spindle cells of the tumor. That's the focal, not really diffuse. This is the next stain I'm showing here is CD117, which preferentially stains the Cajal cells, which give rise to which give rise to the gastrointestinal stromal tumor, and the CD117 is negative in the tumor cells. So could this be GIST? Maybe. Morphology will be okay, but CD117 completely negative, DOG1 very focal. Another marker for GIST, which used to be used a lot, is CD34. It's not used very much because it's not very specific, but it's pretty sensitive, so we did it too. It's diffuse positive. Otherwise, cytokeratins negative, neuroendocrine markers negative, melanoma markers negative. GIST is still number one option, but given the focal staining, we decided to do molecular testing, and we found PDGFRA mutation, which is perfect for GIST. This is the second most common mutation in GIST. The most common is KIT mutation. This is in some 85% of cases of GIST, KIT mutation. The second most common is PDGFRA. And GISTs caused by PDGFRA mutation are frequently focally positive or negative for the GIST markers.
Why tumor, yeah?
No, GIST, gastrointestinal stromal tumor.
Oh, okay.
Yeah, so we already had a SDH-deficient GIST. That's, I think, the fourth most common alteration, and these tumors are somewhat different from conventional GISTs. But PDGFRA and KIT mutated GISTs are the two most common molecular types, and they are treated similarly. Otherwise, GIST can be, you don't say if it's benign or malignant, you give risk assessment score, where you basically say, based on mitotic figures, size of the tumor, location, whether it's stomach or small intestine or other location in the gastrointestinal tract, you say what's the percentage, what's the risk of progression in percent, how many percent of patients with these features progressed. The good thing about this case is that we have such a small sample that I don't have to do it. I'm done with it. Okay, next case was a vocal cord lesion, 40-year-old male. And what we have here are just fragments of the superficial squamous epithelium, which are normal, there is no dysplasia. And then the stroma beneath, it's kind of funny, unusual looking. With this very bland spindle cell proliferation, a little bit myxoid, so there's some extracellular matrix in it, and it sometimes forms these funny nodules with hyalinized areas. If you do immunohistochemistry, this will be negative for any significant marker, so there is no cytokeratin S100 expression, nothing like that. And this is basically an example of vocal cord polyps or Singer's, sometimes it's called Singer's nodule. And indeed, clinically, it was said the patient has a Reinke edema of vocal cords, so this fits nicely. So it's a completely benign lesion, kind of related to overuse of the vocal cords. So this is a 65-year-old female with chronic laryngitis, and this is again lesion in her vocal cords. And this is the same lesion in another patient. This is somewhat bigger, somewhat more myxoid. Otherwise, it looks the same. Again, very bland spindle cell proliferation, no mitotic activity, no atypia. The cells look very similar. In some parts, you can see these nodules being formed. Somewhat kind of helpful morphological clue for this lesion in here as well. This is the best area. The nodules with fibrinous or hyalinized core. So Singer's nodule or vocal cord polyp, completely benign. Another lesion in the vocal cords. This is a 71-year-old male. Okay, so we have small fragments, not that small, Okay, so this is another part. So this looks different, right? So we have again polypoid lesion, again covered by squamous mucosa. Squamous epithelium looks pretty normal to me.
Vocal cord, yeah.
Yeah, vocal cords. This is ulceration here. It's ulcerated in this part, but otherwise, I don't see any clear-cut dysplasia here. It's pretty normal, but the stroma beneath that is obviously not normal. The surface is somewhat myxoid, hypocellular, but still you can see scattered ugly cells, hyperchromatic large cells. And when you go to the center of the lesion, it becomes more cellular and super atypical. There is a lot of mitotic activity. There were some atypical mitoses as well. So, you know, in pathology, mitosis is somebody says mitotic figure is not a shameful thing. That's correct. You know, mitosis doesn't mean malignancy, but if you have atypical mitosis, it's an alarming feature which usually signals it might be something malignant. Not always. There are lesions where even atypical mitotic figure doesn't mean malignancy, but in vocal cords, lesion like this is alarming feature. However, the submitting pathologist, he was, you know, he was trying to move us to, he thinks this is degenerative atypia. Some long-standing tumors can have degenerative atypia, which may show hyperchromasia and so on, but for me this was too much, especially because of the atypical mitoses which were found at some places. I don't want to spend too much time on this, but you have to you have to trust me. There are atypical mitoses. So we did some, of course, basic immunohistochemical staining, mainly cytokeratins, which showed multifocal expression. Expression like this or of this extent doesn't automatically mean it's a carcinoma, but if you look closely, the expression seems to be in the ugly cells, so that would be, you know, more in keeping with the fact that this could be some form of sarcomatoid carcinoma. So, you know, carcinoma should have epithelial differentiation, but if you know, tumors they have a thing called phenotypic plasticity. They can change their phenotype, their appearance, and if epithelial tumors change to spindle cell morphology, it means they look like a sarcoma, sarcomatoid. So this would be called, if this is indeed originally epithelial tumor, which looks like this, it would be called sarcomatoid carcinoma. But because the submitting pathologist didn't believe it's malignant, we did molecular. There was TP53 mutation, PIK3CA mutation, FGFR3 mutation, so all three mutations are common in malignant tumors. And also there was, if you do copy number analysis of the whole genome, you'll find in malignant tumors you'll more often find a lot of gains and losses of chromosomal content, because malignant tumors have crazy genomes. If it was benign tumor, it would be much more likely to have very silent genome, like no gains and losses. And this had gains and losses, a lot of them. So in combination, this morphology, molecular, immuno shows that, or supports that this is a malignant lesion. And given the morphology, location, and cytokeratin expression, this is most likely sarcomatoid carcinoma. So very, very...
Be careful about these lesions, because false positivity is very tragic.
Yeah.
It's worse than amputation of the lung, because they would cut for the whole life, they would have here.
Yeah, I was
very careful about these lesions.
I was pretty sure this is malignant, but still I showed it to Marián, he agreed. Then I sounded out. Yeah.
We both agreed that it's malignant. Yeah, we don't see like epithelial dysplasia in the superficial epithelium, but it still could be somewhere else. It's small biopsy. They should probably perform more biopsies or perform core limited excision, chordectomy first, confirm the diagnosis, and after that maybe proceed to more aggressive surgery. So
from what I know, it has healed very well. It looks like there is nothing, but they still do re-excision, local re-excision, no major operation. But
I'm pretty sure it will very fast come back. Okay, it's sarcomatoid carcinoma. It's aggressive lesion. Yeah.
Hopefully not, but we'll see. So last case, 68-year-old male patient with a tumor in the orifice of the ureter in his urinary bladder. The patient has had a recurrent urothelial carcinoma and had repeated endoscopic operations. So this always, every finding, morphology, immunomolecular, always, evaluated in the clinical context. So this patient has a history of cancer and also a history of repeated endoscopic surgeries. Both can be, can be related to what you see here. So now they have this lesion, fragments of, I think like 3 centimeters grossly. And you see very, very cellular lesion, but higher power cells are pretty monomorphic, pretty uniform. They are spindled. So could this be carcinoma? If it's spindled, of course, it can be carcinoma. It could be, again, sarcomatoid carcinoma, urological cancer. Very often transforms to sarcomatoid carcinoma, but it's very monotonous. There's basically no atypia. This is one of the lesions where there is a high mitotic activity. You can see multiple mitoses here, but you don't see atypical mitosis anywhere. Again, another mitosis here. You would find maybe a dozen per 10 high power fields. So uniform morphology, spindle cell morphology, a lot of mitosis, but no atypical mitosis. And now it's time for some immunophenotyping. So there was a history of cancer, so you may do cytokeratins. So this is control, and this is the tumor. So diffusely positive for cytokeratins. So could this be sarcomatoid carcinoma? Yes, it could be, but that doesn't mean this is the only option. There are diffuse cytokeratin expression doesn't mean carcinoma automatically always.
Especially in this location.
Especially not in this location. Yeah.
I would say that this diffuse and strong cytokeratin positivity speaks against.
Sarcomatoid urothelial carcinoma would be most likely focal or
This location is atypical. Yeah.
Also, P63 was done, which I think it would be positive in sarcomatoid urothelial carcinoma, right? If it was not too undifferentiated. So P63 is negative. Then you do smooth muscle actin.
Is it positive?
Yeah.
It's diffusely positive. All the cells almost.
It's not rare tumor at all. We have many of them in our files.
And if you look at the spindle cells,
Myofibroblastoma.
yes, you see the tumor cell nuclei, and you can see the expression being very strong at each side of basically the cytoplasmic membrane. So this is perfect pattern for myofibroblasts. We also did ALK. I'll tell you why. It was negative. Get back to it if I don't forget. And I think there was some desmin expression too, maybe. Doesn't really matter much. It may be or may not. Anyway, this is a lesion. So the differential now is sarcomatoid urothelial carcinoma, or a lesion called pseudosarcomatous myofibroblastic proliferation. PMP is the shortcut. Pseudosarcomatous, that means looks like a sarcoma. Myofibroblastic proliferation, which is a well-known reactive lesion related to any injury to the urinary bladder, mostly mucosa, or urological tract, but most commonly in urinary bladder. And given the morphology, actin, diffuse, nice myofibroblastic expression and the diffuse cytokeratin expression. This speaks against the carcinoma.
It's always cytokeratin positive. I've never seen it cytokeratin negative.
Yeah, so it's a pitfall. You have to remember that there is this lesion in the urinary bladder, and don't forget when.
And it's benign.
Yeah, it's completely benign. Yeah.
It's benign, and in the past it used to be called like post-operative spindle cell, myxoid, IMT-like proliferation, whatever. Many names in the literature, and this pseudosarcomatous.
Diagnosing is tragic as well.
Yeah. I would say that this diffuse strong cytokeratin positivity is very helpful and diagnostic for that, because for sarcomatous carcinoma you would not expect this diffuse and strong positivity. Okay, so I would call it's helpful sign, not misleading. Okay, it's diagnostic.
If you know about this lesion.
Yeah.
Another useful marker is Desmina finally found it. It's very diffusely positive here.
Yeah.
It's also helpful. It would be unusual to have this in carcinoma. Also, about 50% of these cases are ALK positive, and they have ALK gene fusion, which kind of speaks against being purely reactive lesion. Some part is neoplastic. It's hard to say sometimes what's reactive, what's neoplastic. So ALK can help you, and many people think it's a different tumor than inflammatory myofibroblastic tumor, which looks similar, has ALK fusions very often, but it happens in different locations usually.
But still, if it occurs in site after some instrumentation operation, it's reactive, non-plastic.
Anyway, if you call it inflammatory myofibroblasttic tumor, not much happens. The metastatic rate is like 5%, so it's very low grade lesion, treated accordingly, but don't call it sarcomatoid carcinoma. Okay, that's all. Thank you for your attention, and we will meet here in 2 weeks. Next week is we have a national congress, so we don't do multi-head seminar. So in 2 weeks we will be back. Thank you for listening.